Greetings, online students. I hope you're having a wonderful weekend. I am going to be recording the neurological systems, the basics of it, just so that you have a good grasp of the content before we get started on the pediatric neurological disorders. So without further ado, I'll get started. If you have any questions or concerns, please let me know and I'll be glad to help you. All right, as we get ready to look at neurological system, it is quite important that we remember some of the basic stuff, so we'll be starting from the basics. If I have put this PowerPoint on your content module for you to follow along and take notes as well. I'll refer you sometimes to the book. All right, the nervous system cells. We know that there are two types of nervous system cells. There's the neuron and the neuroglia. When we're talking about these types of cells, they have different types of characteristics. First, when we look at the characteristics of the neurons, well, we know that they are the specialists. And what do they specialize in? Impulse conduction. And they are classified according to two types of criteria. One is the direction in which they conduct impulses, and two is the number of processes that they have. So again, if you were to ask me what are they specialists of, I would say they're a specialist and have two characteristics: excitability and conductivity. Excitability and conductivity. Well, let's look at the direction in which they conduct impulses. Afferent or sensory neurons transmit the nerve impulses to the spinal cord of brain. So sensory goes to. Efferent or motor neurons, of course, transmit impulses away from the brain and spinal cord to the muscles. So that's what causes the actual movement, as in the word motor. The interneurons conduct impulses from sensory to motor neurons. So when we think about the sensory or the afferent, those facilitate sensation. When we think about the motor or the efferent, those facilitate movement. All right, let's look at the second process here, and that's the number of processes that they have. They can have multipolar neurons, and that's where they only have one axon but several dendrites. They can have bipolar neurons, which I think I've got a few of those, and they only have one axon and one dendrite. Or unipolar neurons that originate in the embryo as a bipolar, so it's going to be a one-on-one. But in the course of development, something happens, they fuse together, and you really can't distinguish the axon from the dendrite, so it doesn't work quite right. As far as looking at the structure of the neurons, all your neurons has to consist of a cell body and at least two processes, one axon and one or more dendrites. So this is what's composed of the structure of a neuron. So when we look at the axon, it's a single process that extends out from the cell body and terminates into many branched filaments. It conducts impulses away from the cell body. They can be myelinated or unmyelinated. Of course, if they're myelinated, that means they have white matter or a sheath on there, and that helps develop with movement. In fact, if you're thinking about your newborn, the more myelinated they become, the more they're able to roll over and walk and do other things. The sheath itself is composed, we know, of a white lipid substance, and that acts as an insulator for the conduction of impulses to occur. Okay, as far as looking at the small gaps, there's some small gaps in the myelinated sheath that are called the nodes of Ranvier. And then at the end of each axon, there's an enlarged area called the synaptic knob or terminal. And this contains our neurotransmitters. Now, what's some examples of neurotransmitters? Things like acetylcholine, serotonin, and they have inhibiting and excitatory factors depending upon which one that you are talking about. Okay. So, what are the neurotransmitters? Again, I've already talked about some of those. That would be like the acetylcholine, the serotonin, and they do have inhibitory as well as excitatory functions for the most part. So you need to remember those. Okay. So what else affects neuron transmission besides neurotransmitters? Because we know they're at the synaptic knob, they are released like acetylcholine, they go and fire off and make the next one release until it gets to where it's going. Well, factors affecting transmission would be things like the distance between those transmitters, the strength of impulse. Is it a strong impulse or is it a weak impulse? Is there a lack of oxygen, like an anesthesia, that decreases those impulses? A change in pH. We know acidosis depresses the central nervous system, if you'll remember back. Alkalosis excites the central nervous system. And some of your drugs itself, like caffeine, theophylline, can also affect the transmission of neurotransmission. So there's lots of things that can affect that. What is the relationship between sodium, potassium, and chloride in the row of transmission? Well, sodium and chloride we know is outside the cell in the interstitial space. And we know potassium is inside in the intracellular space. And if you'll remember back when you took A&P, it talked about resting membrane potentials. And it talked about, when it's resting, that the potassium's inside the cell, the sodium chloride are outside the cell. But when it has some type of excitatory function that occurs, then we're going to see a change in that. We're going to see depolarization and then repolarization. If you remember that, when the impulse begins, it's depolarization as the sodium comes in and the potassium goes out. And then it does its thing, and then it has to repolarize where the sodium comes back in. The potassium comes back in and the sodium goes back out, and they switch places again. Then it goes back down to an action potential, and it's ready to start the process over again. Again, that was something that we learned in basic A&P. Sodium's on the outside, calcium's on the outside, potassium's on the inside. Again, when it's in the depolarization stage, that's when the potassium is going out, and sodium becomes in. It does its thing, and then once it does that potential, then it goes back into repolarization where the sodium goes back in, the potassium goes back in, and the sodium goes back out. Goodness, I'm tongue-tied today. The dendrites. Well, the dendrites are pretty cool. They are the branched, extensive, like tiny trees. Their distal ends are responsible for a lot of the sensory neurons, and they're called receptors because they receive the information that initiates the conduction. So they receive it, they start it, and they push it towards the cell body. Then it goes down towards the axon, who delivers it to the synaptic knob. Now, the good thing is we start life with about 100 billion dendrites, but things and life choices that we make tend to affect that. For example, alcohol can destroy about 12,000 per drink. Cigarettes can destroy about 15,000. So we tend, because of our life choices, to decrease the amount that we actually have. The characteristics of the neuroglia cells is a little bit different. They do not conduct nerve impulses like the neurons. Instead, they support, they nourish, and they protect the neurons. So they're kind of like the glue that holds everything together. Now, they do vary in size and shape, and they're about 5 to 10 more times numerous than our neurons. Some common types of neuroglia cells include astroglias or astrocytes. These are the star-shaped cells, and they provide the support of the neuron. They also help regulate the chemical environment by being part of what we call the blood-brain barrier. And if you'll remember about the blood-brain barrier, its function was to maintain homeostasis. And how did it do that? Through selective permeability. Normally substance can enter the blood by way of capillaries into the cerebrospinal fluid, and by capillaries into the extracellular fluid. And the barriers are only permeable to certain things like oxygen, carbon dioxide, anesthesia, water, and it's only slightly permeable to electrolytes. And it's very impermeable to fixed acid bases in most of your drugs. So it's there as a protection. The oligodendrites are form the myelin sheaths in the central nervous system, so they help with protection and movement. The epididymal cells form part of the blood-brain barrier as well, and they also produce and help regulate the composition of cerebral spinal fluid. As well as looking at the microglia, which appear to be phagocytic in function. So they usually are very small stationary cells, but when something becomes inflamed or you have some type of degenerating brain tissue, they will enlarge and move about and carry on phagocytic activity. Now, brain tumors that arise from neuroglia cells, they don't arise from neurons. So when someone says they have a brain tumor, it's involving one of these types of cells. Now, the number one tumor of the brain is an astrocytoma. So thinking about that name, which one of these would be responsible? The astroglias or astrocytes. And the neuroglia cells are capable of mitosis, that's breaking down of cells into stages, whereas your neurons are not, and that's why they are the ones that are responsible for your brain tumors. The neurons do not replicate, they can't replace themselves if they're irreversibly damaged. Neuroglia are unlimited and can replicate themselves. The nervous system has two major divisions. One is the central nervous system, and the other is the peripheral nervous system. This chart, you may not be able to see it too good, but it kind of helps break it down for you. You have your nervous system. You have your central versus your peripheral. The central nervous system further breaks down into the brain and spinal cord. The peripheral nervous system further breaks down into the afferent and the efferent, and the efferent breaks into the autonomic and the somatic nervous system, with the autonomic further breaking down into the sympathetic and parasympathetic. Again, this is just a review. The peripheral nervous system, we know, is composed of 12 pairs of cranial nerves and 31 pairs of spinal nerves. And it's divided again into the somatic and the autonomic nervous system. We know the somatic is the one that supplies the nerves to our skeletal muscles and helps with movement. The autonomic is our regulation of our things like our cardiovascular, our respiratory, and our endocrine, and it's further divided into the sympathetic and parasympathetic. Differences between the sympathetic and the parasympathetic. If we're looking under the sympathetic, its main goal is to maintain what we call homeostasis. It can increase the activity if it's necessary in times of need. Sympathetic responses to stress would be what we call our fight or flight response. It's when we kick things into high gear. So let's say you sat down to your computer, and I said, surprise, we are having a 50-point quiz today. You only have one attempt and 1 hour. Begin. What do you think would happen to your sympathetic responses to this stress? Well, your pupils would dilate. Why? They're looking for an exit. So your pupils dilate, your heart rate increases, your blood pressure increases because your anxiety is out of the roof, your bronchioles dilated, so you take these real deep, heavy sighs, and your anal sphincter, which should slam shut. Because why? We are doing the sympathetic responses to stress, and that's what we're going to see. Pupils dilating, heart rate increasing, blood pressure increasing, bronchioles dilating, and your anal sphincter slamming shut. Good news, I'm not going to do that to you. It's what we call the adrenaline rush. The parasympathetic, on the other hand, conserves your body's resources. They're involved in the control of pressure, respirations, your GI reflexes, sexual reflexes, the bladder, your day-to-day things that preserve you. So that would be the things that like feeding activities, breathing, elimination, circulation. Okay. Now, what's unique is the different parts of the nervous system are constantly interacting, and they're so well coordinated that humans can think, we can feel, and act on many different levels without serious confusion most of the time. All right, the central nervous system is composed, we said earlier, of the brain and the spinal cord. The brain and the spinal coverings, we know are got a lot of bones in here. We got a lot of bones in the vertebral column that encase the cord. And there's a lot of cranial bones. In fact, there's about 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, and then 5 fused in the sacral area, with 4 fused in the coccyx. There's about 8 bones of the cranium around the brain and about 14 facial bones, so lots of bones. As far as the membranes, there's 3 layers, remember, of the meninges. There is the dura mater, and I think of her as the tough mother. She's the white fibrous outermost layer that protects. There is the acronoid membrane, and this is the subacronoid space. That's more of our delicate membrane. It's the middle layer, and it's where cerebral spinal fluid is produced. Then you have the pia mater, which is the tender sweet mother. This is the transparent layer that's directly attached to the surface of the cord and the brain. So it contains your blood vessels, it's your nutritive layer, it's what protects, just like a tender sweet mother would do. Your cerebral spinal fluid is what's between the subacronoid space, and it serves as a protective cushion. What's found in cerebral spinal fluid? Water, glucose, sodium, and protein. Now, usually it's clear, it's colorless, it has a specific gravity of about 1.007. The average patient's ventricular and subacronoid system have around 150 mils of cerebral spinal fluid to start with. Where we get into trouble is when we get excessive formation or we have blockage and it's not getting reabsorbed. And we'll be talking about those issues when we talk about hydrocephalus and some of those things. Spinal cord. It's the downward continuation of the medulla oblongata. That's a fun word to say, isn't it? It starts at the level of the foramen magnum and it ends at about L2. That's important to know because a lot of things we're going to do when you go in and do spinal taps is below that. So if you have someone who knows what they're doing, no one should ever get paralyzed from a lumbar puncture because they go below the level of the L2. Now, it's about 17 to 18 inches long in the average body, and it is the site of reflex pathways. There are 6 structures of the brain. There is the cerebrum, which is the largest part of our brain, about 80% of the weight. It's divided into 2 spheres, the right and the left being the dominant. The left specializing in like language function, dominating control of certain movements. It's contralateral. That means affects the opposite side. So it controls muscles on the right side if it's in the left hemisphere. The right hemisphere perceives a lot of our non-speech sounds, our melodies, our laughters, our crying, our coughing, our perceptions. The right and left hemisphere is divided into 4 lobes. You've got the frontal, the parietal, the temporal, and the occipital. The frontal is responsible for our personality, behavior, and our higher intellectual functioning. So this is where we have a lot of our creative thinking, our problem solving, and I know what some of you are thinking. I was cheated. I know I was. Fine motor movements is also located there. Now in your parietal lobe, this is the perception of general sensation, abstraction, root finding, the sense of direction. This is what's lost early in Alzheimer's disease. Calculations, proprioceptions, that's position sense and vibration sense that y'all tested for. Touch discrimination, 2-point discrimination, and if you don't remember those, we did those when we did our head to toe, and you need to go back and review them. Graphothesis versus steronogenesis. Graphothesis is like a graph. Think of the word graph or drawing. So you have someone close their eyes and you draw a figure in their hand and ask them what you're drawing, like the figure 8. That's graphothesis. Steronogenesis is when you place an object in your hand and you ask them to identify it, like a key. Damage to the parietal lobe can lead to what we call apraxia, which is decreased ability to use objects correctly. apraxia. So that's what can happen to damage of the parietal lobe. The temporal lobe receives stimulation from your senses. It integrates memory, the limbic system, all of those things like hallucinations, illusions, and deja vu. Have you ever had deja vu? Man, I know I've done this before. I know I've been there. That is your temporal lobe responsible for that. Occipital lobe integrates your visual stimulation, and a lot of your tumors can be located in that area. The diencephalon lies on top of the brainstem, and it has two major components, the hypothalamus and the thalamus. We know the hypothalamus controls our appetite, our temperature, our balance, our motion, whereas the thalamus acts as a relay point for all of the sensory tracts except olfactory. It helps control all of the primitive responses. If you'll remember, our thalamus also plays a role in our perception of pain and alertness. It's kind of like the central switchboard. The cerebellum, if you always see the word cerebellum, think balance. So if something goes wrong with the cerebellum, they're going to almost always result in what's called cerebral ataxia, which means a staggering, unsteady, wide-based gait. Okay, so it does affect your posture and your movement. The brainstem, which is the bulb that connects the brain and the spinal cord that lights up the cerebrum, has three parts, the midbrain, the pons, and the medulla oblongata. The midbrain is kind of like the pathway or reflex control center, whereas the pons has the respiratory center, and that's important to know later on when we talk about some of these disorders like anencephaly. And the medulla oblongata controls certain functions of the cardiac, the respiratory, the GI, and vascular motor systems. So if you have a damage to the medulla oblongata, you can see where you're going to have issues for a lot of different systems. The limbic system is your fifth lobe that's wrapped around the top of the brainstem, and it controls your rhythms, your sexual behavior, your emotions, your fears, your rage, normal memory. Oops, you're in trouble. Just kidding. Angriness, sadness, happiness, and some people feel like a lot of your mental disorders are affected by the limbic load having some damage or some other things, episodic dyscontrol syndrome. Yes, this is the final structure known as the reticular activating system. It's the gatekeeper of our consciousness. It affects a lot of our sleep-wake pattern. So we know as we get older, it gets a little confused and we don't sleep as well as we used to. A and P, pediatric differences. It's very important to know these. When you think about the child, they're very top-heavy. That means they have, because of that larger head, they have weak neck muscles, so they cannot control things as well. And that's very important to know because then that makes them more prone to, hold on just a second, more prone to injury. The cranial nerves, the cranial bones are very thin and not well developed, and they're unfused sutures at the beginning. Remember when the posterior fontanelles and the anterior fontanelles close. You need to remember those. Cranial bones, with them being thin, they're going to be prone to fractures, increase intracranial pressure. The subarachnoid spaces are small. Well, if the subarachnoid space is small, we know that's where the cerebral spinal fluid is located. They're going to have less cushion for the brain if they do have a head injury. Ossification of vertebral bodies are incomplete. If they're incomplete at birth, then they've got a greater risk for compression fractures of the vertebrae with falls, even small falls. That's why it's important to really monitor them. Assessment guidelines, you want to make sure that you're assessing them using the correct developmental age and theorist as you're doing that. All right, so what factors contribute to the slower reflexes and longer responses that are seen in the elderly? Well, there's lots of things that contribute to that. For one thing, their reflexes are slower. They've got a decreased conduction time. They may have decreased myelinization over the years. The quality of their neurotransmitters aren't what they used to be. Maybe they made some lifestyle choices that weren't good. So there's lots of things that make those reflexes slower and longer as we get older. Oh, your favorite. Review the cranial nerves. Cranial nerve number 1, olfactory, and 2, optic, hopefully those sounded real familiar, are our central nervous system nerves. That means they have no regenerative capacity. The rest of them have capacity to regenerate because they're peripheral system nerves. It's just a little thing on Old Olympus towering top, but Finn in German viewed some hop. That's a way to remember, and I know there's some other one out there, but I'm not familiar with that one. It's really unique, the blood pathway, when we think about the brain, because it actually flows against gravity. The arteries fill in from the bottom, and the veins drain it from the top. So cerebral veins do not have valves to prevent the blood from flowing backwards. That's why when we start those IVs, we always start them downward, and it seems a little odd, but that's why, because of the flow. Again, here's our thing to go over these cranial nerves again. 1 is olfactory, 2 is optic, 3 is ocular motor, 4 is trochlear, 5 is trigeminal, 6 is abducens, 7 is facial, 8 is acoustic, 9 is glossopharyngeal, 10 is vagus, 11 spinal accessory, and 12 hypoglossal. Close your eyes right now and see how many you can remember. If it's not very many, you might want to review this. All right, so how does aging affect cranial nerve function? Well, lots of ways. Think about it. Let's think about number 1, olfactory. As we get older, our smell diminishes. That's why older people don't like to taste food and eat as much. Optic. It's affected. Farsightedness with diminished near vision. We have reduced ability to differentiate colors as we get older, so optic's affected. Ocular motor, trochlear, and abducens, 3, 4, and 6. We have a slower time of adjusting to light changes. Accommodation's not as good as it used to be. Cranial number 5, trigeminal. Usually there's no normal neurological changes in facial simulation or in chewing, even though we do chew maybe a little slower because of our teeth. Cranial number 7, facial. We do have a decreased sense of taste as we get older. Otherwise, it should be intact. 8, acoustic, is affected a lot by aging. Middle to high frequency hearing loss is common. 9 and 10, the glossopharyngeal and vagus. We have a reduced gag reflex as we get older. 11, spinal accessory. We ought to be able to pull up our muscles, even though we may not do it with as much oomph. And hypoglossal 12, we ought to be able to stick out our tongue at anybody at any age. All right, the development of the nervous system. The nervous system develops from the neural plate and the ectodermal plate, and this appears at about the 18th day of life. The neural plate develops into what's called the neural tube and the neural crest cells. The neural tube then further develops into the central nervous system, and the neural crest cells develop into the peripheral nervous system. Now, what's significant is that during the 3rd or 4th week of gestation, the fetus is very vulnerable to congenital defects related to failure of this neural tube to close. And if it doesn't close, then we end up with what's called neural tube defects, and we will be discussing those in great detail. So for you visual people, we've got the neural plate, the ectodermal plate at about 18 days of life. This develops into the neural tube and the neural crest cells. The neural tube should close by 3 to 4 weeks and become the central nervous system by the end of the 5th week. The neural crest cells becomes the peripheral nervous system. So if we do not have closure here, then we're going to have some problems called neural tube defects. By the end of the 5th week of gestation, most of your basic structures of the nervous system have been formed, and myelinization of nerves continues for several years after birth. The brain continues to grow, forming new tissues until approximately 10 to 12 years of age. And this is just a review of how the brain grows at different ages. The cerebral cortex that governs thought, reasoning, memory is not fully developed at birth. And the big thing is voluntary movement. That's why we don't come out crawling and walking. The brainstem and the spinal cord dominate neurological functioning during this time. Again, that explains the primitive infantile reflexes that start to disappear between 6 weeks and 2 years as the cerebral cortex is maturing. Changes related to aging that affect the nervous system. The elderly, we've already talked about, they may have developed fixed postures, muscle rigidity, tremors, slowness in their movements. And a lot of that's because of loss of brain cells and brain weight. Yes, our brain shrinks as we get older. Decreased blood supply, altered function of the hypothalamus that results in altered sleep patterns, and decreased ability to regulate body temperature. That's why they stay cold all the time and get cold easier. And decrease in nerve impulse conduction. That's both in sensory and motor conduction, so they don't get around as fast as they used to. Bad news, they say peak intelligence is said to be at about 24 years of age, and at age 30 you start going downhill. As far as assessment of the nervous system, you want to make sure that you look at the book and read over a little bit of that in the chapter, but I'm going to hit some high points here that will help you if you're ever taking care of a neuro patient. Health history. Important health information. You need to remember 3 points. Avoid suggesting symptoms to a patient, because once you do that, then that patient thinks, oh, but well, maybe I do have that kind of pain. Yes, it is dull now that you mentioned it. Let them tell you what's going on. The mode of onset and course of the illness are especially important aspects of the history, and to know that. Many of your neurological diseases affect a patient's mental functioning, so make sure that they are alert and oriented ×4 and that you're getting factual information. A big note is that neuro patients almost never suddenly go bad. They give you clues that they are deteriorating, so it's important that you pick up on that, especially if you're going to work on a neuro floor. There are 5 steps of the neurological assessment, and this is a review. Mental status exam. Y'all have been over and over that. You know about your mental status exam, your cerebral function. The cranial nerve assessment. We've already been over that. Reflex testing, motor system testing, and sensory. So we'll do a quick review of each one of these. Step 1 was mental status, and you'll remember we come in and we looked at someone's general appearance and behavior. We looked at their state of consciousness. Are they alert and oriented ×4? It says the most sensitive indicator of changes in neurological status of a patient is their state of consciousness. Listen to the family. If they say Uncle Joe's not acting right, this isn't his norm, something's not right. Mood and affect. You know, that's important to assess. The verbal and nonverbal cues, are they matching up? Is their emotional status appropriate? Thought content. You know, are they having illusions, hallucinations, paranoia? Intellectual capacity. Do they have some type of restriction, such as dementia or mental slowness in their intelligence? All right, when we're also doing this, we need to remember the terminology that we can use for unexpected levels of consciousness. One of those is confusion. I stay in that level of consciousness. Mental slowness, impaired decision-making, check. Lethargy, drowsiness, falling asleep quickly, sluggish, but you are arousable. Obtunded. You are arousable, but only with stimuli. And we'll talk about some of the stimuli that you have to use. I have put in an article on neuro assessment that you will need to look at. Delirium, a state of confusion with agitation and hallucinations. Stupor. You're arousable for short periods, but that's it. And it requires vigorous and repeated stimulus to keep you awake. Coma, non-arousable, absence of reflexes. You're neither awake nor aware. The Glasgow coma scale is a scale that encompasses 3 types of behavior. If you'll remember with this one, you're looking at eye opening, the best verbal response, and the best motor response. With this one, remember your high score you can get on a Glasgow coma scale is 15, and the lowest is 3. If it's below a 7, then you're considered to be in a coma. Which one of these would you have to adapt for children? The verbal, because infants can't tell you and talk to you. So there's another scale that you use for them. That's the one that you would have to adapt. Stimulation. Many times, research tells us that we do not stimulate our patients enough to get a true picture of their neurological response. And stimulation falls in the following sequence: voice, shout, shake, and pain. So I go to wake up my 16-year-old daughter who won't get out of the bed. The first time I walk by, I use my sweet voice. It's time to get up and go to school, hon. The next 5 minutes I walk by and I use my shouting voice. I said it's time to get up and go to school. The next time I go by, we have an issue, so now it's time for the shaking process. You go in and give them a little shake. It's time to get up and go to school now. If those do not work, then it's time to elicit a little pain. Not really, but I'm just trying to give you a stimulation here. Sorry, someone came in. I had to shut my door. So with pain, you would actually elicit some type of pain. Throw some water in their face or something. So that was just an example. Don't be hurting anybody. But read that article because it tells you about pain and how to elicit pain if you're trying to get central pain versus spinal pain. So you knee or peripheral pain. So make sure that you read that article. Painful stimulation falls into two main categories, central and peripheral. With central pain, we use the trapeze squeeze, the supraorbital pressure, and the sternal rub. With the peripheral, the spine responds to peripheral stimulation. That's nail bed pressure. Again, make sure you read your article. It goes over these. The second step is the cranial nerve assessment, and you will need to review that on your own. Just glance through that and make sure you remember how to assess each cranial nerve. The third step is reflex testing. If you'll remember, it's often graded on a scale of 0 to 4. 0 meaning absent, 1 hypoactive. Usually they're hypoactive, it's usually a lower motor neuron disease. There's some type of damage to the spinal cord or there's a metabolic disorder. 2 is normal. 3 is hyperactive and brisk, like increased or exaggerated response. And then 4 is hyperactive with sustained clonus, C-L-O-N-U-S. And usually if they're hyperactive with sustained clonus, that means they have a presence of a central nervous system disorder. Okay. These are usually written as a fraction, like 2 out of 4 was their reflex, which means, 2 is normal. Out of a 4-point scale, they got a 2. Now, we're bad about just charting present, absent, or diminished. But if you work on a true neuro floor, then you will actually elicit reflexes and grade them as such. This takes practice. You know that from doing it. A lot of you had trouble eliciting some of the major reflexes, which was the biceps, the brachioradialis, the triceps, the patellar, and the Achilles. The big thing you're watching for when you do these is asymmetry. Now, a lot of the findings, again, depend upon the proper use of your hammer, proper positioning, and a relaxed patient. So make sure, again, that you go back and review these if you've forgotten how to do those. Remember, we also checked for the Babinski response, where we took the end of the hammer and did it in an upside-down J on the bottom of the foot. And you'll remember that that's indicative of central nervous system disease that affects the corticospinal tracts. The sole of the foot, if they have a central nervous system, if the central nervous system is intact, the toes will contract and draw together. If they have central nervous system disease, the toes fan out and draw back as in dorsiflexion. Remember that it's normal up to the age of 1 year to have a positive Babinski. And that's what we just went over. Okay, sorry, a little behind there. The fourth step is the motor system assessment. This is the highest level of normal response you'll see to following commands. Muscle strength is tested by assessing the patient's ability to flex or extend their extremity against resistance. This is also on a grading scale, 5 being normal against resistance, 4 being weak against resistance, 3 being sufficient strength to overcome the force of gravity but not resistance. 2 is move in, they can move, but they can't overcome the force of gravity. 1 is minimal contract power, and 0 is no contraction, total paralyzed. So to give you an example of what that means, if we start here looking at 5, full power of contraction, normal against resistance. Let's say we go in and see Mr. Smith, and we ask Mr. Smith to move his arm, and there's no movement. He gets a 0 out of 5. The next time I go in and ask Mr. Smith to move his arm, he can't move it, but I can actually see or feel the biceps twitching as if he's trying. That is a 1, minimal contractile power. The next time I go in and I ask him, I can see his wrist and fingers move, but he cannot lift his hand up. So there's some movement, but he can't overcome the force of gravity. Then he gets a 2 out of 5. The next time I go in, he can actually lift his arm, but as soon as I touch it, it falls back down. That's a 3. He has sufficient strength to overcome the force of gravity, but not resistance. Any resistance, it falls back down. If I go in the next time and he can lift his arm completely up and we can Indian wrestle a little bit, but he's weak and loses, he gets a 4. Then if I go in and try to push his arm down, but it stays completely up, then, or he beats me at Indian wrestling, he gets a normal 5 out of 5. Maybe that helped make that more sense than just looking at those numbers. Balance and coordination are also tested. You observe for the patient's stature, their gait, their coordination. Remember, you did the finger to nose test. You did the pronation summation on both hands hitting their legs rapidly, and the heel to shin test. Abnormal posturing is common in comatose patients. You have decorticate and decelerate. Decorticate means going towards the core, so they have rigid flexion. The arms move towards the core of the body. This usually indicates partial brain functioning is still present. Decelerate is the worst of the two. You have rigid extension, where the arms extend out from the body. This one is caused by more brain damage and usually more severe. The fifth and final step is the sensory system assessment. This is throughout your assessment with the patient's eyes closed, and you tested for these in your head to toe. That was light touch. Tell me when you feel this, and you were doing that with the cotton ball. Pain and temperature. We did sharp and dull, and if they have that intact, then temperature's intact. Vibration sense. You took the tuning fork and put that against their great toe, and they told you when they felt it. Position sense is when you bend the toe up or down and ask them which direction that you're bending it. 2-point discrimination is where you have 2 points and you come more and you tell them when it is 1. And then grathesis and steronogenesis we've already talked about. Recording the assessment is always important. You have to have good documentation and document everything you do using correct terminology, especially if you get out and work on a neuro floor. Diagnostic studies of the neural system, you need to review those in your book and look up on those so that you are familiar with them. And Dr. Ball will be covering most of those throughout her lecture, and in the PEDS content I will cover specific ones that have to do with specific neurological disorders. All right, that's the hard part. Any questions, let me know. Again, this is just a general overview. Most of the stuff you've already had, but it's to get you in the neuro frame of mind that you need to be in to start these disorders. Thank you.